Oh man.
'Tis the season.
Right. A question about that exam. Is that something we have to sign up for early, or is that just something that's automatic when we're done these classes?
No. What you will want to do is when it gets closer to the end of the class, I would recommend going on the AAPC website and you can search for exams. And when you search for the exams, you're going to find the dates that are available for you to sit for exams. So once the class is done, you can let Amy know what date and location you want. She has to physically sign you up because she has to send the payment into them. It's not an automatic thing.
Okay.
But you need to pick your date and location.
Okay.
So I always tell people to look at the dates that are out there. There's typically, the Portland chapter does at least 4 a year. So typically it's 1 per quarter. This year, the Lewiston chapter, we ended up doing, I think we did 6 exams because of the number of people that wanted to sit for exams. So it is possible that other dates will open up, but the sooner you let her know and get signed up, you're guaranteed a spot.
Guarantee a spot. Okay.
Yeah. Because I think they limit it to 20 people because of the space, because we have to allot you your own table.
Right.
So they do limit the number that we can proctor.
Okay. Good to know. Okay.
Yep. So can everybody else hear me okay?
Can you hear us in Ellsworth?
I can now, yep.
Great. I don't know have you heard from Jeannie?
I have not.
Okay. She'll probably be right along. I'm
Okay,
the
no problem.
coordinator. Yeah.
Okay.
Yeah.
Have either one of you received your HickPick book yet?
No.
Okay. The week before last, so the week that I was out sick, did you do anything or did you just leave it? Because I planned on tonight doing those lectures from that week that I was sick, as long as you guys didn't go ahead and already listen to them online. The only chapter I obviously can't do is the HickPick one yet, because we don't have that book. So what my intention is to start with the modifier chapter, go through that, skip to chapter 12, which is an anesthesia chapter, because that's a short chapter and I know those 2 we can get done tonight, and then jump back and start with chapter 11, which is the evaluation and management. That one, even we probably would not finish it all tonight anyways, but we can get 10, 12, start 11, and then next week finish 11, and then do 13 general surgery and start integumentary, and then we'll be back on schedule. And when we get the books for HickPicks, that's a fairly abbreviated chapter, so we'll just do that one whenever we get the books. If that sounds all right for everybody.
Yep.
Okay, perfect. So we'll give Our Lady in Ellsworth just a couple of minutes. Otherwise, I'll go ahead and get started right at 5:30 for you guys. I'm not sure if I mentioned this before or not, but I'm not sure if we will be holding another one, but we did it in, I think it was September. The Lawston chapter held a CPC exam review class. We joined together with the Portland chapter, and we held a review class for people that were going to be sitting for the exam. So I know it has been mentioned that they hope to do that next year for 2018. I'm hoping that they will try to do it like for the spring when you guys are ready to sit, like in March or April.
Yep.
And if they do that, I will send, if it's after class is done before you guys actually go for the exam, I'll send you an email so that you're aware, and if you want to attend, I think we charged $15 last time, and what that covered was the expense of lunch. We brought lunch in from, I think it was Portland Pie, and it covered lunch, and we did a 5-hour review, very similar to what we'll do in class, but a little bit more in depth. So
Yeah, that'd be awesome.
yeah, people seem to like it a lot. They felt
Yeah.
more comfortable and more ready to sit for the exams.
Right. And we're gonna go over it as well.
Yeah.
Okay.
Yeah, we spend the last week of class after we're done everything. We take that CPC exam review book.
Yeah.
That's actually your study guide to use when you're at home. You can go through each individual chapter, but we take the exam itself, and I'll have you make, some people will make copies because if they're like me, I'll X out as I go through, and I wanted to be able to take it as many times as I needed to
Right.
feel comfortable. So I just made copies, and I picked certain ones. Some of them you can see there's, one answer, A, B, C, D, and there's only one code per, answer. Those are pretty straightforward. I go through and I pick the ones that are a little bit more, not questionable, but ones that might stump you, or ones that might be looking for something specific to see if you pick up on it. And what we do is we just go through, we don't do the entire exam, but we'll walk through I would say we do more than 75 questions. So we do more, just about half or a little bit more. And you get the feel for how to process of eliminate and what they're looking for.
Yeah.
And then I tell you, use that test and keep practicing until you can get it in that time allotment of 5 hours and 40 minutes. And then you've got your pre, your post, and the final exam on Evolve. So you've got another 3 exams that you can continue to practice with until you're comfortable with the time. Because when I proctored the one last month, everybody, when they were done, that was their biggest thing, was time. I think we had 12 people sit for the exam, and when time was up, we had only had one person that had left, and that person that had finished early wasn't taking the CPC exam. She was taking a specialty exam, so that wasn't surprising that she finished early.
Right.
Everybody else was right down to the wire, and they were filling in circles just to get some of them answered. So that's the biggest
So
thing.
what is it,
for
like
lot
a
of
set
people.
amount of questions?
There's
that you
150.
haven't finished?
Yeah, 150 questions. So if you figure that out, which I think I've done before, it's two
And
and
it's
a
5.5
half.
hours?
It's 5.5 hours, so it's 2.5 minutes per question.
Jeez.
Yeah, and you've got to get 70% correct to pass. Yeah, so that's the biggest thing. So, all All right, well, what I'll do is I'll go ahead and get started. If Janine comes in Ellsworth, she can just pick up and start in where she comes in. So again, we will start with the chapter 10, which is modifiers. We are going to go over each individual modifier, let you know what it's used for, indications for it. I will tell you that I'm going to go through it from your textbook, but in your appendix, you have modifiers in two different places. You have an abbreviated version on the inside cover of your CPT book. So that gives you, again, an abbreviated description of the modifier. And then in the back of your CPT book in Appendix A is another complete list of the modifiers, a little bit more in depth. So it doesn't matter where you follow along. If you want to follow along in the appendix as I go through and make notes in there where you're going to be able to use that for your exam, that is completely up to you. But we will go through all of the modifiers one by one. So modifiers, what they do is they may affect the payment with your CPT codes that you use. And modifiers help describe, sometimes in more detail, the CPT code that we are using. Modifiers can let the insurance company know if a service has been altered, if the service is greater than usual, if there are unusual circumstances, if something was discontinued, if they only did a portion of the test, bilateral, multiple procedures, professional part versus technical part, and we'll go over that more than one physician. So again, your modifiers complete the story, so to speak. And there are numerous modifiers. I will tell you, depending on the type of practice you are in, you may only use a handful of them. You may only use a couple of them. Some of them are targeted by the OIG for overuse. Does that mean that if you use it all the time, you're in trouble? No, not as long as you are using it properly. So it is okay to use the modifiers. We just have to make sure that it's indicated. So the first modifier is modifier 22, which is increased procedural service. So what I like to say about this one is you would use this if it is extenuating circumstances and the procedure that the provider is doing is greater than normal. So they had excessive blood loss, or they're doing abdominal surgery and there's adhesions. So that procedure that should have taken an hour took 3 hours because he had to go through all the adhesions. Trauma, anything like that. 22 is a modifier that if the insurance company reviews it with the note, because when this modifier is used, you do need to send documentation with it. So that is one of the things you have to remember. A lot of the modifiers you can just throw on the claim and send it. You don't need to attach the documentation. This one you do. So what the insurance company will do is they'll actually read the report and they will see if they feel that it was above and beyond. And if it was, your provider may get a little bit more reimbursement than he normally would. So that's what the modifier 22 does. It is valid for codes with global periods, so that means you can use it during the postoperative period. The next one is modifier 23. This is used by anesthesiologists to indicate a service for which general anesthesia was used when normally the anesthesia would have been local or regional. The reason they have to use a modifier is because if they had to use anesthesia, then they want to get paid for for that. If they don't use this modifier, then the fee that they are going to get reimbursed includes just the local anesthesia. So they're not going to get the regular general anesthesia. The modifier 23 is only used with codes from the anesthesia section. So when we cover chapter 12 tonight, if there are any examples in there that state something about general anesthesia, modifier 23 can only be used with anesthesia codes. On page 257, 24, unrelated evaluation and management by the same physician or other qualified professional during a post-operative period. So it tells us that during a post-operative period, the patient came back and saw us for something unrelated to the surgery or the post-operative, post-global period. So, for example, let's say we do a knee arthroscopy on a patient for a torn meniscus. And that patient 3 weeks later slips on the ice and breaks her wrist. When she comes in to see us, when we try to bill an office visit, if we would not put this modifier 24 to say it's unrelated, they're going to tell us she's in the global period and they're not going to pay us. So if we want to get paid for an office visit that is unrelated to the global period, you build a regular office visit code, which we'll talk about in the evaluation and management section. You put the modifier 24 on it and you will get paid for that office visit. So that's the 24 modifier. 25, significant separately identifiable E&M service by the same physician or other qualified professional on the same day of the procedure or other service. So the best way to explain this, there has to be medical necessity to provide a separate additional E&M code on the same day as a procedure was performed. That E&M documentation, again, needs to support that. So let's say you have rectal bleeding and you present to your gastroenterologist and you see the gastroenterologist. It's a significant amount of blood, and the day you see the gastroenterologist, he says, we need to take you over to the hospital. You need to have a colonoscopy today. So what happens is you bill an office visit, you put the 25 modifier on it, and then you're going to bill the colonoscopy the same day. So what that does is it tells the insurances that at the time the patient was in for the office visit, we did not know that we were going to do another service until we did an exam. And it allows us to get paid for both. If we see them in the office, and like today, we saw a lady for a child, for a broken humerus. And when the kid came into the office, it was evident that the kid needed surgery. So what ended up happening is we saw him in the office, and they went to the OR less than an hour later. So we billed for the office visit, we put the modifier, and then we billed for the surgery. If I had not put a modifier on the office visit, and I billed the office visit and the surgery with no modifier, what the insurance company is going to do, and they'll do it because they can, they're going to pick which one they're going to pay you. And 9 times out of 10, they're going to pay you the cheaper one. So they'll pay you the office visit, and then they'll tell you they can't pay you the procedure. All it needs is that modifier 25 on the E&M code, and you will get reimbursed both. The modifier 26 This is to designate a professional component of a procedure that has professional and technical components. Most of the codes that have professional and technical components, for example, are X-rays, EKGs. What the professional component is the physician's interpretation of that test. What the technical component is the equipment, the machine. So when you go to the hospital and have an X-ray, the hospital will bill for the X-ray with a TC modifier for technical component, and the radiologist that reads the X-ray bills the same X-ray code with a 26 modifier. They each get paid their own portion. I believe what it is, I think it's 60-40. So I think it's 60% for the technical component and 40% for the interpretation. But if you don't use the appropriate modifier, then what they're going to do, so let's say I billed it as if we did the whole kit and caboodle. They're going to pay me the whole thing. But then what happens when they get the bill from the radiologist saying he read it with his modifier? They're going to deny his claim because they've already paid us. So you just have to make sure if you are doing the entire thing, you own the equipment and you are interpreting, then you bill the whole thing. But if you are only doing a portion, it would be a 26 modifier for the professional component and a TC modifier for the technical component. These examples, these exercises, I'm going to let you do these ones and the ones in your workbook because they break it up by section, so they're pretty straightforward. On page 260, 32 modifier. This indicates a service that is required by some third-party payers. So, for example, a second opinion requested by a patient, a family member, another family member, a life insurance company, anything like that, we would use a 32 modifier to indicate that a third-party payer mandated a physical exam of a covered patient. So typically you may only find this one if workers' comp mandates a physical exam on somebody, or a life insurance policy. Disability insurance sometimes will mandate, and you would use this modifier. So again, this is one that you may or may not ever use. 33, preventative service. So with the Patient Protection and Affordable Care Act, requires health insurance coverage of preventative services and immunizations without cost. So typically, only 33 would be if you were providing preventative services, either family care, internal medicine, or possibly pediatrics. 47, anesthesia by a surgeon. This is used to report a surgical procedure in which the surgeon administered regional or general anesthesia to the patient. So in other words, there was not an anesthesiologist available to do it, so the provider had to do it himself. In this case, by using this modifier, it will allow the provider to get paid extra for that monitoring of the anesthesia, which normally the anesthesiologist would get paid for. So again, depending, may only be like emergency type basis if your provider is doing that where there's no anesthesiologist available. 50, bilateral procedures. If the same procedure is performed on a mirror image organ of the body, then modifier 50 would be indicated so that they know it was done on both sides. Bilateral mastectomy, for example, would be 19303 and 19303 with a 50 modifier. You can do bilateral two ways. You can do it the way I just said, so you can put the CPT code and then the same CPT code with the modifier 50, or you can use that code 19303 with an RT for right, and then the same CPT code with an LT for left. The only way you're going to know which way to do it is ask the insurance carrier how they want it. Because I will tell you, Medicare, they want the 50, but some of the smaller insurance companies, want the RT and the LT. So this is where you need to go by what the carriers want. But again, 50 is bilateral. And if you look under the CMS rules on 261, it says be sure to find out whether your third-party payer wants it once with a modifier 50 or twice or again with the RT and LT. Modifier 51 is multiple procedures. So anytime somebody has surgery, more than one procedure can be performed. It's called multiple procedures. And if you look down at the bottom, with the multiple procedures, it gives the example above the CMS rules: benign skin lesion, excised from the chest, closure using layered closure. 11406 is excision of benign lesion, and then we've got the layered closure, 12032 with the modifier 51, because we did more than one procedure. So anytime we do more than one procedure at the same operative setting, what ends up happening is your reimbursement is going to be affected. So by using the modifier 51, it lets the insurance company know. Granted, they can see if you've listed 4 different procedures, but we've got to follow coding guidelines, so we use the modifier. And then they will reimburse you appropriately from there. Typically, multiple procedures, your initial procedure, you will get 100% of the allowable, and then the additional procedures are reduced from there. Typically 50% for your second, third, and then sometimes they will drop down to 25% for anything above 3 procedures. But if you look on page 262, we want to be careful when we use the modifier 51 that we are not either unbundling or bundling, and we'll talk more about what those are. But unbundling is assigning multiple codes when there is one code to describe the service. So, for example, hysterectomy with bilateral salpingo-oophorectomy. So they're removing your tubes and your ovaries. There is one code out there for both of those procedures. So it would be incorrect for us to bill the hysterectomy and then the removal of the ovaries with the modifier 51 is what they are telling us. However, if one code does not describe all of the procedures, then we can list them in addition with the modifier 51. There are 3 significant times when we can report multiple procedures: same operation, different site; multiple operations, same operative session; and procedure performed multiple times. So one of the ones that I like to use for the multiple times is being an orthopedic office. We see a lot of people with trigger fingers, and usually they have more than one trigger finger. So if that is the case, when we take them to surgery, they're already under. We are going to fix all 3 of their trigger fingers while they're in there. So it's the same CPT code, but we've got to use the appropriate modifiers to tell them it was multiple procedures. Multiple operation, same operative session. Primary procedure would be paid at the full fee. Second procedure would be paid 50% of the fee, and the third, 25%. And sometimes this varies depending to the insurance company, but don't let your providers think that just because they've done 3 different procedures and, they're $5,000 procedure each, that's what they're getting paid, because they will be reduced. Procedure performed multiple times So this is the trigger finger, for example. And in your HCPC book, when you get it, you will notice that, there are HCPC modifiers for your fingers and your toes. So when we do procedures on our fingers and toes, we want to use those modifiers. They are also listed in the front cover of your CPT book. So you don't always have to go to your HCPC book, but just be aware that if you are coding fingers, toes, eyelids, there's ones for, this is what you would use for modifiers. You will find, again, some of the more specific, more common HCPC codes, again, on the front cover and in Appendix A. So you will find them in both locations. HCPC modifiers are listed, if you look at the coding shot, in ascending alphabetical order. So when you use the alpha HCPCs, you want to put them in order from A to Z. So, for example, if you are using AS for assistant modifier, assistant surgeon, and then F8 for one of the fingers or toes, you will put the AS first and then the F8 after. So your HCPC modifiers go in ascending order. If you look on page 264, it gives you some examples of the 50 modifier, again, either using it with the 50 or the RT and the LT. Some examples of the modifier 51, and then some with the digit HCPC modifiers. You will see the caution next to the time symbol. Modifier 51 is not going to be used on CPT codes that say each, because that CPT code specifically says each. If we use that CPT code, we are going to bill it by the number of units instead. So if we took 4 lesions, it would be 4 units. We would not list that CPT code and then list it 3 more times with a 51 modifier. So if the word each shows up, no 51 modifier. And that is a good example of what they try to get you on the exam. Because you will have 4 different choices. One of them will be with a 51 modifier, and then another one will be times or whatever with the units. And you need to remember that if you see each, it goes by units, not modifier. Modifier 52 is reduced services. It's used to indicate a service was provided but was reduced in comparison to the full description. So an example of this would be a surgical procedure removing an abdominal carcinoma. Patient was anesthetized, excision begun, and then it was terminated because when the physician got in there, he realized it had metastasized too far and there was no point to resume the procedure. But he started, so you still bill that CPT code with the modifier 22, and the insurance company will at least pay you for the portion that you did. So it's not like you're not going to get anything. But again, modifier 52, reduced services. If you look on 266, under the CMS rules, modifier 52 cannot be used with evaluation and management codes. So for me, in order for me to remember that, I would either right next to the 52 modifier in the appendix, write no E&M codes, or in the E&M section in my CPT book, right at the very beginning, I put no modifier 52. Just like with the anesthesia. If you went to the anesthesia section and put that modifier that can only be used with the anesthesia codes. That, however, it's easier for you to find. 53 is a discontinued procedure. So 52 describes that it was reduced at the discretion of the physician. Modifier 53 says it was stopped because of patient status. So 53 would be more like the patient went into atrial fibrillation and they had to stop the procedure. Or the patient started hemorrhaging and they had to stop the procedure. So be careful with 52 and 53. So 53 would not be used when the patient cancels the procedure. 53 cannot be used with E&M codes. And 53 cannot be used with any code that is based on time. So again, just little tidbits like that, because you may get an answer on your exam that had a time code and it would have the 53 modifier. And if you know that that modifier can't be used with a code that is documented by time, then right there you can eliminate that answer. 54, 55, and 56. There may be times when you would perform only the surgery and another physician would do the pre-op eval or post-op eval. So if they do only the surgery, they would do the modifier 54. If they do only the post-op, 55. If they do only the pre-op, 56. So let's say, for example, patients up here, they're a student at a school up here, and they break their something. And the doctor up here is going to do the preoperative assessment, but the family wants them to go back to Massachusetts and have the surgery there. So the physician up here that does the pre-op would bill whatever code would be appropriate with the modifier for the pre-op. When they get down to Massachusetts and they have the surgery, then that physician that is performing the surgery and possibly the post-operative care would bill that code with the other two modifiers. If the patient ends up back up here and that same physician sees him for the post-operative care, then we could bill the post-operative with that modifier. But the reason there's 3 different modifiers for the pre, the surgery, and the post is because of how they pay for it. So if you perform the surgery, obviously they're going to give you the bulk of the money. If you do only the pre or the post-op assessment, you're not going to get paid as much. And that can happen with people that deliver a baby, for example, as well. So 54, 55, and 56. So 54 is the surgical care only. And again, this is a percentage of the global surgical package. 55 is post-operative management only. And 56 is pre-operative management only. And again, in the back of your CPT book, they give more descriptive with regards to each of those modifiers as well. You will see that under 56, there's a CMS rule. We love Medicare, we love the federal government. Modifier 56 is never used when you submit claims to Medicare. So this is where knowing how your payers want things submitted is also going to help you know what modifiers you can use and when you can use them. 57 is a decision for surgery. This is reported with an E&M code to indicate the day the decision to perform a major surgery was made. It can be reported not only with E&M codes to indicate the initial decision, but also with I codes in the medicine section. 57 requests payment for that office visit outside of the global package. Not all modifiers are recognized by third-party payers, but again, we want to follow coding guidelines, and then the payers will decide whether or not they accept those modifiers. If you have a E&M service provided the day before or the day of major surgery, typically that is included in the global package. So the exception would be if you are seeing a patient the day before or the day of, and it's decided that they need surgery right then, the modifier 57 is what is going to get you paid for that surgery. Okay? So again, 57. Modifier 25, again, is basically the same type of modifier, but 25 is for minor services and 57 is major surgical procedures. So the 25 would be used more for an injection, possibly, or a cast. And then the 57 would be used actually for somebody going in for an actual surgical procedure. Okay, so 25 and 57, minor and major. 58, staged or related by the same physician or other qualified professional during the postoperative period. So this notifies the payer that a subsequent surgery was planned or staged at the time of the first surgery. The procedure must have been intended to include the original procedure plus one or more subsequent procedures. So this would be used in the instance of multiple skin grafts. They are done in stages. So the modifier would be added to the subsequent submission of codes. A patient may have a surgical breast biopsy. And if that pathology comes back saying it's malignant, the patient may decide to have a mastectomy. That would be staged or related. So again, 58 modifier. And again, some of these modifiers, if you do not have a surgeon that you're billing for, you may not use those modifiers. Modifier 58 requests full payment for a subsequent procedure that may have been planned in follow-up. So again, this is one of those situations where if you do not put that modifier, if you're within that global period, they're probably not going to pay you anything at all. So then you've just lost that reimbursement for your provider, and we want to make sure to get them everything they deserve as long as we are billing it appropriately. 59 is distinct procedural service. So this indicates services that are usually bundled into one payment were done as separate procedures. So 59 is one that's targeted by the Office of the Inspector General. So again, if you use modifier 59, it's okay to use it. Let's just make sure we're using it properly because you will get audited on this code, on this modifier. So we can use 59 to identify different session, different procedure or surgery, different site or organ, separate incision or excision, separate lesion, separate injury or area of injury, and extensive injuries. Medicare has a list of what we call NCCI edits, which is National Correct Coding Initiatives. And you can go out on Medicare's website and you can print it for the range of CPT codes that you use for surgery. But what it will do is you can look up a CPT code, and if Medicare allows you to use modifier 59 for that CPT code, it will tell you that you can use it. If there is under no circumstances ever that you can use the modifier 59 with that code, it will also tell you that. And it does so by using a 0 or a 1. And I'm trying to remember which is which. I think if it's a 0, it can never be used. And if it's a 1, it is possible you may be able to use that modifier with supporting documentation. So we use the modifier 59 when we go in and do knee surgeries because you've got different compartments of your knee. So if the physician is doing different things in different compartments, sometimes we need to use that modifier 59 so that we get paid appropriately for those additional procedures. Effective January 2015, there are 4 new HCPCS modifiers. in addition to 59. So we have an XE, which is a separate encounter, a service distinct because it occurred during a separate encounter. XS, separate structure or organ. XP, separate practitioner, so done by a different provider. And XU, unusual non-overlapping service. It is distinct because it doesn't overlap usual components. So again, modifier 59 or 4 of the new modifiers may be ones that you use. Again, go ahead.
Sorry. I use this NCCI edits a lot.
Yeah.
Can you print it? Does it change frequently?
It will only change if they change their local coverage determinations and policies. So typically throughout the year, no, but I always go in at the first of the year just to double check and make sure it hasn't changed, because what may happen is if, like, let's say that modifier 59 was a 0 for a lot of procedures that cardiologists did. If the cardiologists themselves go to their cardiology organization and they go through all the hoops and everything that they need to and go to Medicare, it is possible that sometimes that will change, and it may change to a 1. But it's an act of Congress to get it to happen. So I only check mine once a year.
Okay.
I
go in fresh every time because my manager said it can change, so you have to do it every time. And I'm like, oh my gosh.
Yeah, typically if it's going to change, it's only going to change after the first of the year. We don't check ours more than that. I just print it and use it from there.
Yeah. Okay.
So, yeah. So again, modifier 59 requests payment for a procedure performed on the same day as another procedure that normally would not be reimbursed separate. So that is why we use the modifier 59. And again, it's targeted by the OIG. So if we are using 59, just make sure you're using it properly. 62, 2 surgeons acting as co-surgeons. So 2 physicians, different specialties, have to have worked together as co-surgeons, and each doctor has to dictate their own note. So what happens with that is each doctor is going to bill the same CPT code with that modifier and have their own documentation, and they will get paid appropriately. If the physician does not document as a co-surgeon, then they can't bill that with that modifier 62. The only way they're going to be able to bill it is if they've documented their own notes. And a lot of times, if they're from 2 different specialties, what it means is that Dr. A's office has to call Dr. B's office and make sure that they are both billing the same CPT code. Because obviously, if they're co-surgeons, you want the CPT codes to match. The reimbursement is 125% of the fee schedule. So that means each provider is getting, 62.5% of reimbursement. So they each get paid half. 63 is a procedure performed on an infant less than 4 kilograms or less than 8.8 pounds. This modifier is not used with the integumentary system, and you will have some codes with parenthetical notes that tell you do not use modifier 63 with certain codes. So again, reading it and making sure you're looking around the whole thing to know whether or not you can use this. Sometimes the code description is going to say that, however the wording is, it's going to say procedure done on newborn weighing 8 pounds. Well, if the procedure code already says that, there's no need to use the modifier. Okay? 66 is a surgical team. So complex surgical procedures requiring several physicians, different specialties, more than 2, it would have to be. And they will use, each does their own part. So they each bill their CPT code for the component they did. And the third party payers will typically increase the total reimbursement for the team and then divide it based on the arrangements that they have with those providers. So again, this is one of those that you probably never really know how much you're going to get paid until the bill gets in and they see how many providers have participated. 274, modifier 76, repeat procedure or service by same physician or other healthcare professional. This would be reported on services repeated by the same physician to indicate to the third party payer that the services are not duplicate, the bill is not duplicate. Sometimes these repeat procedures are done on the same day, but without the modifier 76, they're going to assume it's a duplicate billing and they will not pay it. So, you know, that patient that was bleeding has the colonoscopy in the morning and goes home and starts hemorrhaging again. The patient ends up back later that day to have another procedure. That would be an example of that modifier so that they get paid for the procedure that was done in the morning and the procedure that was done in the afternoon, because otherwise to the insurance company, you're billing it on the same date of service, the same CPT code. So to them, it looks like a duplicate charge. 77, repeat procedure by another physician. So this is exactly the same as 76, only it's not the same physician that did the original surgery. It's somebody else. So maybe Dr. A was in the hospital only in the morning, and then he left on vacation. And now Dr. S is in the afternoon and gets called in to do it. That would be the 77 modifier. 78 on page 275. Unplanned return to the OR or procedure room by the same physician or other qualified professional following initial procedure for a related procedure during the postoperative period. So the patient's returning to the OR for surgical treatment of a complication that resulted from the first procedure. So again, this indicates to the third-party payer that the second surgery was necessary because of complications from the first surgery. So again, you would run into the same situation if you don't use the modifier 78 and you're taking them back to the OR for another surgery during the global period. You're not going to get paid because you're in that global window. They don't care what procedure you do. It's global. So you have to indicate it's 78, unplanned. So you can see they give an example of a patient that had a open heart coronary bypass. They left the operating room and they had to go back because of hemorrhaging. So on that second procedure, they used the modifier 78. And unfortunately, the same day, he had to go in again. So they use it a third time in order for them to get paid. An operating procedure room is defined as a place of service specifically equipped and staffed for the sole purpose of doing procedures. So 78 could not be used in the office setting if it's not staffed solely for procedures. So this typically is your OR or procedure ambulatory surgery center, something like that. 79, unrelated procedure by the same physician or other qualified professional during the postoperative period. So this says that a patient requires surgery for a condition totally unrelated to the condition for which the surgery was performed. So this is our lady who had the knee arthroscopy, and now she's fallen and broken her wrist, and she's in the hospital, and we need to do wrist surgery. She's still during the global period, but we're going to use that modifier 79 on the surgical procedure because it's unrelated to the procedure we already did. And that way, again, we will get reimbursed. 80 is an assistant surgeon, which is an extra pair of hands to the primary physician. They are reported with the same code as the primary surgeon with the modifier 80, which says assistant surgeon. And typically their reimbursement is 15 to 30% of the usual charge. Again, it depends on the insurance carrier because they're just an extra pair of hands. If it's a minor procedure, that percentage could be a lot less. Depends on the insurance carrier and the procedure. If you look at the caution, a physician assistant providing assist at surgery would use a HCPCS modifier AS, not a modifier 80. So for our nurse practitioner, when she assists at surgery, the modifier we use for our nurse practitioner is AS, not 80. She is a physician assistant. She is not an assistant surgeon. And as you are well aware, just because you get authorization from an insurance company, it does not guarantee payment. And that's something that anytime you are doing procedures or your physician is doing procedures, patients assume that because the doctor said it needed to be done, it's going to be covered, and that is not always the case. 81 is a minimal assist, an assistant surgeon who provides services less extensive than the assistant surgeon. It's not commonly used, but there may be times when they're in there only for a portion of the procedure. A lot of third-party payers don't pay for minimal assist. They consider it a courtesy. So, again, how are you going to know whether or not they pay? You're not until you bill it. But that is something that if my provider is doing, let's say they go in on carpal tunnels and they're using this modifier 81 for minimal assist and they're not getting paid, I need to let them know that, because if they're spending an hour in the OR with a physician and they're not getting paid, then maybe they need to see office patients or something else in order to make sure they've got money coming in. 82 is an assistant surgeon when a qualified resident is not available. So this would be when the hospital where the procedure performed has a teaching facility and there is, or a residency program, and there's no resident that can assist with surgery. Then the assistant surgeon would use the modifier 82 so that they get paid. Because if a procedure is done in a teaching hospital and a resident is available, that's how they learn. So they don't get paid. So if somebody else is doing it other than a resident, they have to put that modifier, or otherwise they will not get paid. And that's part of their agreement with the facilities. If it's a teaching facility, the resident should be available to do that. On page 278, modifier 90, used to indicate services of an outside lab. So again, this would be related to pathology and laboratory testing. So may or may not be applicable depending on the type of provider. 91, repeat clinical diagnostic lab test. It indicates that a test performed on the same day or was performed on the same day as the original test. Now, this modifier you wouldn't use if it's repeated because of a malfunction of the equipment. You would use it if, let's say, the patient goes in the morning for a glucose test and it's really low, and the provider says, go eat, go do your normal routine, come back this afternoon, we're going to redraw it. that would be an example of it. But if it's because the tech couldn't draw it or the equipment malfunctioned, that is not an example of a repeat test. 92, alternative laboratory platform testing. This would be when there is a kit or transportable instrument used in a lab test, such as an HIV kit. So if it's drawn in the office and then transported to the hospital, again, so a lot of offices don't draw blood anymore. They send patients strictly to the lab for it, so this may or may not be used. 95, telemedicine. When a provider and patient interact from separate locations and there is a star symbol next to the code, you would bill that CPT code with this modifier. Now again, remember, just because there are CPT codes, just because there are modifiers, doesn't mean they're all reimbursed. This is a good example of that. The telemedicine, few insurance companies will reimburse for it, but not many. And the last modifier is 99. This is needed only if the third-party payer does not accept multiple modifiers. So if we are doing something where we have, for example, the modifier 78, and then we have F8 and F9. So we've got 3 modifiers we want to use, but the insurance carrier we're billing only accepts 1 modifier on the claim. Then we would use the modifier 99. 9 times out of 10, they're going to ask for documentation. They will read it. They will pull out the same modifiers that we would have, those 3 modifiers we would have billed had we been able to list them, and then they will pay you from there. But there may also be some practice management systems that are limited on the number of modifiers that you can put in your system. So if that's another example of when you may only be able to use 1. And if you look at the bottom of 279, you will see on the claim form where those blue arrows are, we have the availability to list 4 modifiers. Usually, unless you're coding pretty complex procedures or maybe cardiology procedures, you're probably not going to need 4 at the same time, or unless you did all 5 trigger fingers. But we do have the capability to list 4 on each line item. So just be aware of that. Any questions with regards to the modifiers? Modifiers, again, they're pretty straightforward. There will be some that you will use more than others, and others that you will not use at all. And you'll see that some of the examples we do when we get to the practice exam, I will pull examples of the modifiers so you can see what kind of stuff they're looking at to try to stump you. All right, so let's go to chapter 12, which is anesthesia. And what we're doing now that we've covered how to use the CPT and the ICD-9, now we're starting at the front of your CPT book, and we're just going to cover each individual chapter in your CPT book. Obviously, evaluation management is the first one, but it's also fairly large. So we're going to skip and start with anesthesia. So your anesthesia section in your CPT book should begin roughly around page 53. It's the blue section in your CPT book. And we'll go over types of anesthesia, the format of anesthesia, the formula, reporting issues, and how to report anesthesia services. So the types of anesthesia, they are only used by anesthesiologists, anesthetists, or another physician to report provision of anesthesia services, typically during surgery. So anesthesia means induction or administration of a drug to obtain partial or complete loss of sensation. and analgesia is absence of pain. Types of anesthesia can be general, regional, local, or what we call monitored anesthesia care, or MAC, which is conscious sedation. Conscious sedation is not reported with anesthesia codes. They are reported with conscious sedation codes in the medicine section. Local anesthesia is usually administered by the surgeon, and typically if it's administered by the surgeon and it's local, like for example to take off a ganglion cyst, the surgeon injects a local and removes the cyst. That local anesthetic is typically included in the removal of the cyst. So that's why it's important for, if you're coding anesthesia, we need to know the type so we know whether or not we can bill for it. The American Society of Anesthesiologists defines the practice of anesthesiology. So the management of procedures for rendering a patient insensible to pain and emotional stress during a procedure, the evaluation and management of essential physiologic functions under the stress of anesthetic and surgical manipulations, clinical management of the patient unconscious from whatever cause, evaluation and management of acute or chronic pain, management of problems in cardiac and respiratory resuscitation, application of specific methods of respiratory therapy, and clinical management of fluid, electrolyte, and metabolic disturbances. So those are all different situations when anesthesia may be required and used. Some types of anesthesia are named for the site that they are administered: sacral, lumbal, caudal. Other types are named for the category: freezing, cryo anesthesia. Some of the more common ones you will see will be endotracheal. This is insertion of a tube into the nose or mouth. Epidural, injection of the anesthetic agent into the epidural spaces in the vertebrae. It's also called an epidural block. Spinal, anesthesia produced by an injection of local anesthetic into the subarachnoid space of the spinal cord. General, state of unconsciousness accomplished by use of drug or combinations of drugs, either given IM, intramuscular, rectally, IV, or inhaling. Regional anesthesia interrupts sensory nerve conductivity in a region of the body and is produced by a field block or a nerve block. Under regional, you'll see that there's also something called a blood patch, which is when cerebral spinal fluid leak is closed by means of an injection of the patient's blood into the epidural space. Obviously, this is one that would only happen in that particular situation, so not a very common one. And then local anesthesia by means of application of an anesthetic agent, lidocaine, or topical, placed directly over the area being treated. It can also be a subcutaneous injection as well. Now, everybody reacts differently to anesthesia, and you can react differently to each one of those types. A lot of times children do better if they are given the anesthetic via an injection versus inhaling it. Like sometimes they knock them out with gas. Sometimes they're very combative when they come out of that situation, but they react differently when they're given an injection. So a lot of times they will ask you if you've had reactions in the past, because one may work better than others for you. If you look on 348, couple pictures of a couple of different means of those methods. There's also patient-controlled analgesia, which allows you to administer it to control pain. So when you have a major procedure, you'll be hooked up to a pump, and with a little press of a button, you can administer your own pain medication. That would be an example of that. Down at the bottom, there's also called monitored anesthesia care, or MAC. MAC is provided by an anesthesiologist or a certified registered nurse anesthetist. And the patient is monitored, if necessary, sedation provided, even general anesthesia. General anesthesia is used for cases requiring deep sedation, so open heart surgery, abdominal surgery. They're not arousable, not able to communicate. Several different types of medication can be used during general anesthesia. So you might be given drugs for pain, sedation, paralytics for muscles. You can be given several different types. Regional anesthesia targets the nerves of the area being treated, and spinal and epidural is administered into the cerebrospinal fluid or the epidural area of the area being treated. And typically, spinals are done for procedures below the waist. And again, between you and the anesthesiologist, they will let you know what they feel is best, and then you can decide from there, especially if you've had them before. Moderate or conscious sedation is a type of sedation provided by a surgeon or the surgeon's staff, such as a nurse, who is performing the procedure. It's a decreased level of consciousness that does not put the patient completely to sleep. Now, I will tell you, with colonoscopies, for example, they're given moderate sedation, conscious sedation. Everybody reacts to that conscious sedation differently. It knocked me out, but it did not knock my husband out. So some people will be completely out and others will not. It can react different. A trained observer needs to be present when moderate sedation services are provided. The codes for conscious sedation are in the medicine section, and that's one of the last sections that we cover, 99151 to 99157. So again, not in the anesthesia section. Code descriptions for moderate conscious sedation include the term intra-service, and intra-service time begins with the administration of the sedation, and it continues face-to-face attendance by the physician and ends when the personal contact with the physician ends. So again, all throughout until they come in and say, see you later, you're done, you're fine. On page 350, again, moderate sedation only reported when the physician performing the procedure administers the sedation. Moderate or conscious sedation methods are less invasive than anesthesia. So again, that is why they are reimbursed differently. So if your provider has to give anesthesia instead of moderate sedation, we want to make sure we use that modifier. That's the one for the surgeon doing the anesthesia, not the anesthesiologist, so that they will get reimbursed. So in the anesthesia section, here is how it's formatted, and each section is typically formatted the same. It's divided first by anatomic site and then the specific type of procedure. So in the anesthesia section, we have radiological procedures, and the codes are 01916 to 01936. We have burn, excision, or debridement, 01951 to 01953, obstetric, 01958 to 01969, and other procedures, 01990 to 01999. Again, this is not a memorization game, so you don't have to go, okay, in the anesthesia section, what are the different sections? Because when you go to look up, for example, anesthesia for burns, it's going to lead you to that range of codes. The big thing you need to remember, especially when you're doing your homework in the anesthesia chapter, is when it asks you to look up a CPT code, for example, for a hysterectomy, you're not actually looking up the CPT code for the hysterectomy. you're looking up a CPT code for anesthesia for the hysterectomy. So in this section, anesthesia, your keyword always wants to be anesthesia first and then the procedure, because you will get two different codes. So anesthesia providers can be the actual anesthesiologist, the CRNA, Certified Registered Nurse Anesthetist, anesthesiologist assistant, a resident who they can't bill for the service anyways, and a student registered nurse anesthetic, and that their billing is based on the specific payers. So what is the formula? How do they decide how they're going to pay for anesthesia? When an anesthesiologist provides anesthesia service to a patient, the pre-operative, intra-operative, and post-operative are all included in the CPT code. These services include usual pre- and post-operative visits. It also includes routine intra-operative care, which is the administration of fluids and or blood and usual monitoring. It includes the history that the anesthesiologist needs to take, the ventilation establishment, giving your pre- and post-operative medications, possible blood pressure, temp, arterial gases, carbon dioxide monitoring. Can include intubation in order to administer the anesthesia. The post-operative care is usually pain management. Sometimes the pain management, if it's like a spinal injection or something like that, if it's above and beyond the usual treatment, then those services can be reported in addition. But if it's routine, normal care for intra, post, and pre, then it is all included. If you look at the very bottom of 351, it tells you, for example, a Swan-Ganz catheter. This is not a normal service provided during a surgery. So we would be able to bill this in addition with the modifier 59. So when we learn to code, again, you will be looking at what you can bill with other things. And sometimes there are a lot of things we can't bill together. But in this instance, the Swan-Ganz is something that is not normally done, so we are able to bill it. If you look on 352, what makes anesthesia coding different is the way the services are billed. So the formula for payment of anesthesia is base unit plus time plus modifying units. So we have B plus T plus M, and then that is multiplied by what the insurance company designates as a conversion factor, which is a dollar amount. So you add the B, the T, and the M, you multiply it by the dollar amount, and that gives us how much they are going to be reimbursed. B, again, base unit. The ASA does publish a relative value guide, which has codes for anesthesia, and it does give the base code so you can have an idea what you might be looking at. So if you look up on 353, you'll see that if you are billing anesthesia for a procedure on esophagus, the base unit is 15 plus time. But if you are doing anesthesia for a closed chest procedure, it's only 5 plus time. So they're going to get paid much more for a procedure done on the esophagus than one done on a closed chest procedure. So the CMS base unit, the RVG, is not a fee schedule. It instead compares anesthesia services with each other. So if you look down at the bottom, again, if it's anesthesia on a closed procedure on the lower leg, ankle, and foot, the base unit's 3. If it's arthroscopic, ankle, foot, still 3. Nerves, muscles, tendons, lower ankle, foot, still 3. But then we have anesthesia for a ruptured Achilles tendon or a gastrocnemius recession, and it goes up to 5. So again, just a guideline so that the anesthesiologist has an idea how much they are getting paid. You can see on 354, CMS does print or publish an annual list of the base units. So if you are billing anesthesia, you can go out there and get that list. One coding circumstance unique to anesthesia occurs when multiple surgical procedures are done during the same session. In this case, only the procedure with the highest base unit would be assigned. So if during the same surgical procedure, a clavicle biopsy, which has 3 base units, and a radical mastectomy, which has 5, is done, you can only bill the 5. So anesthesia is different in that case. They don't allow us to add the base units up. They only allow us to use the highest base unit because we're going to be adding time is why. And again, you can see that CMS has their rules regarding multiple procedures for anesthesia. So if you were doing that, you would want to be aware of their rules. The T for time. The time is based on anesthesia when it was administered in total minutes. So the timing starts when the anesthesiologist begins preparing the patient to receive anesthesia and is in constant attendance with the patient, continuing through the procedure, and ends when the patient is turned over to post-anesthesia caregivers. These minutes have to be documented in the patient record, and carriers determine how many minutes are considered a unit. So again, here, it's not standardized. Medicare, for example, may consider 15 minutes a unit, but Anthem Blue Cross might consider 5 minutes a unit. So that is something we need to be aware of if we were billing anesthesia. Start time should match the time reported on the claim form, as well as the anesthesia record, the CRNA or anesthesiologist billing slip, and anything that has time documented submitted to the insurance company. They should all match, okay? Which makes sense. Always record the actual time. Private payers may or may not reimburse for certified registered nurse anesthetists. They may require that they be performed under a supervising anesthesiologist. When we are preparing the claim, again, always record actual time that indicates the ending time of personal attendance. And again, the start time on the anesthesia record should match the time reported on the claim form and indicate beginning time of service. So again, that's real important. M is for modifying unit. Modifying units reflect circumstances or conditions that can change or modify the environment for anesthesia. So we have qualifying circumstances and physical status modifiers. And if you open to your anesthesia guidelines, you will see on page 55, there are your physical status modifiers and your qualifying circumstances. So your qualifying circumstances are sometimes the anesthesia is going to be provided in emergency situations, patients of extreme age, people with controlled hypotension, hypothermia. In those 4 situations that you see under qualifying circumstances, you would use those codes in addition to your anesthesia code, and they will help affect your reimbursement. Because if you're doing anesthesia on a patient of extreme age, that is obviously a much higher risk than doing it on a patient who's of normal age with no health conditions. So if you do not use these qualifying circumstances, then you stand no chance for additional reimbursement. So if you look on page 356 and 357, if you ever bill anesthesia, these are the types of reports or records that you will see for you to submit the claims. So again, I know it's hard to read, they're kind of small, but you can see up at the top right-hand corner of the form on 356, there's your anesthesia start and stop time. There's place for the time for blood pressure when they're in recovery, what types of anesthesia or airway management was used, and then everything on the bottom is for them to monitor while they're in attendance of that procedure. And then again, the medical record, pre-anesthesia evaluation and post-anesthesia evaluation are on page 357. So pretty typical formats for anesthesiologist. Nothing that, offices typically stray from. They pretty much use the same forms. And then we're able to bill right off these forms because we have the times. They will give us what procedures were done, and we will have all that information as well as the providers. If you look on 358, again, there's those qualifying circumstances. So if the patient's of extreme age, we're going to get one additional base unit. If they're hypothermic, we get 5 extra base units plus that other 15 that we already got. Complicated by hypotension, 5. Or complicated by emergency, 2. So that's why we want to use them. That extra base unit, if the conversion factor is $50, even at the 1, that's an extra $50 we're getting. You want to look down at 358 and look at the stop sign. Here we want to be careful in our CPT manual for the plus symbol next to any CPT, not just the qualifying circumstances. If we see a plus symbol, which you can see in front of the qualifying circumstance codes, that means that that code cannot be billed by itself and it cannot be billed first. This is another example of what they're going to try to get you on your test. They will list the qualifying circumstance code first instead of the anesthesia code. And you have to be able to know that if that code has a plus symbol in front of it, that code is never going to be first. Then you have your physical status modifiers. These are used in the anesthesia section only, and these modifiers indicate the patient's condition at the time anesthesia was administered and identify the level of complexity. So again, P1 through P6, and you'll see that some of them have 0, because if the patient's a normal, healthy patient, or unfortunately if they're brain dead, we're not going to get paid anymore. There's nothing that adds complexity to that anesthesiologist. But if you throw in the fact that the patient has a severe systemic disease, that's a threat to life, that's going to add another 2 to that base unit. So again, if you are not using these with your anesthesia codes, especially P3, 4, and 5, you could be losing additional money for your provider. Okay? Now, the thing is you need to make sure if you bill for anesthesiologists that your provider is aware that they're there and that they can be used. Because if they don't tell you that the patient has a constant threat to life or a severe systemic disease, we may not know that from just looking at those 2 pieces of paper. So there has to be some way for that provider to relay that information to you. So summing it up, most healthcare facilities have software that automatically do the conversion calculations for them. So again, it's base plus time plus any modifying factors, and that's multiplied by the dollar amount to get your reimbursement. So if you have an 84-year-old female, that makes them of extreme age, so we're going to add 1 extra base unit. Severe hypertension, that adds 1. And they have a malignant lesion removed from her right knee, which has a base of 3. Total time of anesthesia was 60 minutes. And the courier indicates that the unit is 15 minutes, so that would be 4 units there. And then we have 5 units for the base unit. Anesthesiologist recorded that the patient's physical status was a P3 for severe systemic disease, so that's 1. So that adds 5, 4, 9, that's 10. So, or 9, I guess I added wrong. 3, 4, 5, 4 units. Okay, look on 360. 3 for the base procedure value, 4 for time, and 2 for the additional modifiers, so a total of 9. So they would take that conversion factor, which if you look down underneath that, if you are in North Dakota, that conversion factor would be $21.39. So they take that $21.39 times 9. But if you're in New York, it's $24.50. So again, you can see the difference there, $192.51 versus $220.50. But if you forgot those physical status modifiers, right there you're knocking $40 to $50 right off the top of that reimbursement by not using those additional qualifiers. When multiple surgical procedures are done during a single anesthetic administration, again, only bill the anesthesia code with a highest base value unit. Time would be combined, but only the highest base value unit. Assign the code, again, highest base value unit. Indicate cumulative start and stop time for all surgical procedures performed. If you look down again under the coding shot, according to Medicare, we do not use modifier 50, which is bilateral, on anesthesia codes. They don't care that it's bilateral because the base unit is the same one way or the other because they're adding time with it. So they're basing it more on time than they are the fact that it's bilateral. And you can see roughly, unfortunately, the conversion factor for anesthesia does vary depending on location. But again, giving our anesthesiologist an idea, if they ask, what do I get paid if I do anesthesia, for brain surgery versus if I do, an arthroscopy or something. Concurrent modifiers. Some third-party payers require additional modifiers to indicate how many cases the anesthesiologist was performing or directing at one time. Your certified registered nurse anesthetist, they can administer anesthesia to patients under the direction of a licensed physician, or they can work independently. But an anesthesiologist can medically direct up to 4 cases at the same time. If a physician directs more than 4 cases, it's referred to as medical supervision. So here's where they just need to be careful how many cases they are doing at the same time. Because if they end up billing X amount of anesthesia cases during one day, they might say, how the heck did you do 50 cases in a 5-hour period? Because there's no way they can only really handle the 4 at one time. And typically, if you've ever seen them, they come in, they do their assessment, and then once you're in the OR, that's when they give you the medicine and everything starts. Immediately after the procedure is done, you're turned over to the recovery and they're on to their next case. So that's typically how they can go from case to case. And again, you will see that when medical direction occurs, Medicare does require certain documentations. And as I always say, no matter what type of office you end up billing for, it's always in our benefit to make sure we're familiar with the carrier's guidelines. You can see some of those modifiers for anesthesia on page 362. Again, these are HCPCS modifiers, so they will be in your HCPCS book when you get them. I believe they may also, nope, they're not on your front cover. But AA, anesthesia performed personally by the anesthesiologist. AD, medical supervision, so that means they have more than 4. G8, monitored anesthesia for a complicated invasive procedure. G9, patient with cardiopulmonary. QK, medical direction 2, 3, or 4. QS, monitored anesthesia. QX, certified registered nurse anesthetist. QY, the certified registered nurse anesthetist by direction of an anesthesiologist. And then QZ, without direction of physician. So again, these modifiers are not CPT, they are HCPCS modifiers, and anesthesia modifiers are always placed after the CPT code. And again, they can affect your reimbursement. There will be also what we call at the bottom of page 362, unlisted anesthesia codes. When there is no CPT code to indicate an anesthesia service, we have one unlisted anesthesia code, and that is 01999. You will see as we go through the chapters, each section has usually numerous unlisted procedure codes because there will be different body parts. But with anesthesia, if we do not find an actual CPT code for whatever anesthesia we are doing, we can use that unlisted procedure code. So if you look on page 363, obviously we're not going to do one. I just told you what that unlisted one was. But let's look down at number 5, for example. We need to find the anesthesia code for repair of cleft palate. So in your CPT book, where are you going to start in your alphabetical index?
Anesthesia.
Anesthesia, correct. Because again, if you go to repair or cleft palate, you're going to end up with a completely different code. So let's go to anesthesia. And let's see, cleft palate.
Zero 172.
00172, correct. What about number 6? Repair of ruptured Achilles tendon without graft. Repair of ruptured Achilles tendon without graft.
Anesthesia.
Anesthesia.
Would it just be Achilles tendon repair? No, I don't think so.
Well, let's go look at that. 01472. So that would be on page 60. Does that description match?
Yeah.
It does, doesn't it?
Yeah.
So 01542. if it only lists one code and it's specific for Achilles tendon, it's probably the only one. But again, when we learn, we always want to read the description to make sure, in this case, that with or without grafting was there, because sometimes one word can change the whole meaning of the code. Okay, good. So again, remember, keyword, anesthesia. On 364, if a patient is returned to the operating room on the same day for the same or related procedure, and again, the same individual performing the second procedure, we would use a modifier 76. So for example, the anesthesiologist does the service for an upper GI scope, and they report their initial code 00740 with that AA modifier because it was personally done by the anesthesiologist. And later that day, they come in for a lower endoscopic procedure. That anesthesiologist would then bill 00810 with the AA, and again, the 76, or if it was a different anesthesiologist, it would be the 77. So that way they get paid, again, for both procedures done on the same day. Otherwise, the insurance company, they'll pay for one, but they won't pay for the other, and they usually pay the cheaper of the two. Anesthesia, you can see, is not a very big section. So it's pretty straightforward. Again, the main thing you have to remember is your keyword anesthesia. Any questions with regards to anesthesia? Nope. All right, now we'll start in with evaluation and management. So let's go backwards. So in evaluation and management, you will see that this is the red section of your CPT book. Again, it has a index, or not an index, but a outline. And then you also have your green pages, which are your guidelines. Now, again, your guidelines will help you with certain information. So again, you can make notes or do anything that you need here in the guidelines. And you'll see that for evaluation management, we have 8 pages of guidelines. So that information is there to help us. So we're going to talk about the factors of selecting an evaluation and management code. What's the difference between new and established, inpatient and outpatient, the different levels of the E&M services, the different components, talk about history, exam, decision-making, contributing factors, the type of E&M codes, documentation guidelines, and then we're going to show that we can code evaluation and management. So if you look on 284, again, here is the outline of this particular chapter. So we've got codes for office and other outpatient, hospital observation, hospital inpatient, consults, ER, critical care, nursing facility, domiciliary rest home, boarding home, custodial care, domiciliary rest home, assisted living, home care plan oversight, prolonged services, case management, care plan oversight, preventative, non-face-to-face, special E&M, newborn, inpatient neonatal, care management services, transitional care management, advanced care planning, and other. So in this red section, we've got anything that pertains to these codes. Again, if your doctor just strictly does office visits and does not see patients in the hospital, then you're not going to need to worry about those hospital codes. But three factors that we take into consideration for evaluation and management codes are where did it happen, so the place of service, what type of service was it, and the patient status. So if you look on 285, the place of service, that means was it in the office, was it in the hospital, was it in the ER, was it in the nursing home? We need to know where it was so that we can put the appropriate codes. The type of service, was it a consultation? Did somebody ask for a request from one provider to another for their opinion? Was it an admission to the hospital? Was it newborn care? Or was it an office visit, which is face-to-face encounter between physician and patient? And then the patient status. Are they a new patient, established patient, inpatient, or outpatient? A new patient is one who has not received professional services from that physician or another physician in the same specialty within the last 3 years. And established is somebody who has been in within the last 3. And then outpatient is somebody who is not formally admitted, and an inpatient is somebody who is. Now, the insurance companies, with regards to the new and established, they take that seriously because they pay more for a new patient code than they do a follow-up code. So they want to make sure that it's truly been 3 years since you have seen that patient. I love our practice management system in this regard because if my doctor codes a new patient visit, so let's say they saw Dr. A, and now Dr. A is saying, let's go see the back doctor in my practice. So Dr. B bills it as a new patient. My system will actually flag it, and it will tell me that that patient has been seen within the last 3 years. So it enables me to change that code or ask the provider to change that code. So I like the system in that regards. Not all systems do that, but it helps. So we need to know where it was, what type of service, and then is it new, established, inpatient, or outpatient. If you look on 286, medical record documentation. So the information in your medical record is the documentation. This documentation regards the patient's health care. It can affect reimbursement for claims, research, education. It acts as legal documentation. There are 7 organizations, AHIMA, there's AHIMA, American Hospital Association, Managed Care Review Association, the AMA, American Medical Peer Review, Blue Cross Blue Shield, and Health Insurance Association of America. Those 7 organizations developed minimal documentation guidelines. So in other words, they state that the medical record needs to be complete and legible. Documentation of each encounter needs the date of service, the reason for the encounter, history, exam, review of other services, so if they had labs or x-rays, assessment and a plan of care, and then the provider needs to sign it and date it. Past and present diagnoses should be accessible. Reasons for and results of x-rays, labs, and other tests should be clear. Relevant risk factors identified. Patient's progress or response to treatment needs to be documented. If they are non-compliant, that also should be documented. Written plan of treatment needs to include medications, frequency, dosage, if they've been referred somewhere else, any follow-up care. Documentation needs to report intensity of patient evaluation and or treatment, complexity of decision-making, all entries dated and authenticated by the provider, and then the CPT and ICD-10 codes reported on the claim form should reflect and support what is documented in the chart. Because remember, if it is not documented, was not done. So we have various levels of E&M service, again, based on documentation, that consider the skill, effort, time, responsibility, and medical knowledge of the physician. The levels of service are based on key components, which we call history, exam, and medical decision making. They can also include contributing factors, which are counseling, coordinating care, maybe with an outside facility or a hospital out of state, nature of the presenting problem, and time. So again, your key components, history, exam, and decision making. That, again, should be reflected in the documentation. Key components are present in every patient case except counseling. Key components allow you to choose appropriate level of service. We actually typically do not actually select the code for the providers. They are selecting the codes themselves, but we need to understand what the requirements are for them to be able to select that code. So you will see in your CPT book that if you look on page 11, for example, at the first new patient code 99201, you will see that this is a code for a new patient, and it requires 3 key components. So it requires all 3 of those bolded items. While if you were to look at a code for a follow-up patient, it says it only requires 2 key components. So if you flip the page and look at 99212, it says it requires at least 2 of 3. So that's what the provider is keeping in mind when they are selecting their codes. We have to make sure if it requires all 3, that's the only way we're going to be able to select that code is if they meet all 3 of those. If it says they only need 2 of 3, right now it is not mandated which 2 of 3 you need. They can do an exam and medical decision making. They do not need to do a problem-focused history. I think at some point it will be mandated which 2 you have to do, but right now it's not. So look down at the bottom of this page where it says office, new patient. So again, according to E&M guidelines, following categories must meet or exceed the stated level of key components. So you can see all of those sections require all 3 of those key components to be met. If it does not meet all 3, then we're going to be going backwards to the lower codes until we can meet all of that criteria. So look on page 288. This is an example of an E&M audit form. Sometimes once you get your certification, you may decide you want to be an auditor. And when somebody audits, there are forms such as this. And what you do is you take the physician's documentation and you go through and you are checking those components of that documentation to make sure that he has met a problem-focused history, a problem-focused exam, and that his decision-making was moderate. And it's done so by what we call bullets. So each little thing is assigned a bullet, they're tallied up, and then that helps us select the code. So this is just an example of what the audit tool looks like. So what my providers do when they're dictating is they have the availability to look at a typical audit tool. So as they're documenting, if they look at the review of systems, there's 14 different systems. But for orthopedic, for example, they may not cover psychiatric, endocrine, respiratory. So 9 times out of 10, we are probably never going to be able to get a complete review of systems. So we're never going to be able to meet that highest level on some of the things. But just to give you an idea of what they look like. And then the 2 of 3 components, so that means we only need 2, not 3, are for those items listed, and those typically are for follow-up patients, subsequent hospitals, subsequent nursing, subsequent rest home, home established patient. So when they start out, they are taking a history, and the history is the subjective information that the patient tells the provider on 4 elements: their chief complaint, history of present illness, review of systems, and past family and social history. So this history will contain all the information the physician needs to assess the condition. Documentation of the history is found in the patient's medical record, and it needs to be documented by the physician, not the medical assistant or the nurse rooming the patient. So nurses, physicians, and physician's assistants, they're allowed to document some of the history, such as the chief complaint and maybe the past family and social, but the physician must authenticate those entries and then document the rest of it. A physician can have the patient complete a form, which has questionnaires about the review of systems. If that form is filled out, the physician needs to authenticate that information. So in his documentation, he needs to say, history form filled out by patient, reviewed and noted to be positive for, or noted to be negative, whatever it happens to be. If he does not state that he reviewed that history form that the patient filled out, he can't count that towards the level of the office visit. So again, the 4 elements of a history: chief complaint, history of present illness, review of systems, past family, and social. So now we're going to go over what each one of those is. So if you look on 290, chief complaint, again, concise statement, symptom, problem, condition, diagnosis, or other factor for the reason for the encounter, and it's usually in the patient's own words. Now, a lot of times patients will say, I'm here for follow-up. Okay, yes, we know they're here for follow-up, but follow-up of what? Because from an auditing perspective, if I go in and audit a chart and it says patient here for follow-up, that's a non-billable visit. I'll right there tell the provider that they need to send the money back to the insurance carrier. Follow-up of what? History of present illness, chronological description of the development of the patient's present illness from first sign and or symptom to the present. And if you look underneath, location, thoracic spine, burning, throbbing, scale of 1 to 10, how many days, does it happen continuously, morning, afternoon, evening, anything make it worse or better, lying down, bending over, and then anything associated signs and symptoms. What else is present that relates to that chief complaint? The HPI needs to be documented by the physician, so this is not something that the MA or the nurse can put in the chart. Then we have the review of systems. This is an inventory of body systems obtained through a series of questions about what the patient may be experiencing. ROS, inventory of systems to reveal subjective symptoms that the patient either forgot to describe or which at the time may not have been important to them. They may not have realized it was important to their situation. The inventory of systems may be made by means of a questionnaire, again filled out by patient or ancillary staff, but the physician must evaluate the questionnaire and document in the medical record that the questionnaire was reviewed in order for it to count as a review of systems. Here are some review of systems. Constitutional symptoms are weight changes, fever, weakness, and fatigue. Eyes, glasses, contacts, glaucoma, cataracts, ear, nose, mouth, and throat. You can read cardiovascular, chest pain, respiratory, chest pain, gastrointestinal, nausea, vomiting, bleeding, GI, urinary or genital reproductive, musculoskeletal, joint pain or stiffness. Now, all of these review of systems are going to depend on what the patient is there for. Because again, if the patient is there for a orthopedic problem, we're probably going to do constitutional and musculoskeletal, but would it be medically necessary for us to do ear, nose, mouth, and throat? Probably not. Maybe cardiovascular if we were going to do surgery. But again, each of these review of systems need to be medically necessary if we're going to be able to count them. Integumentary, rashes, jaundice, neurologic, psychiatric, endocrine, hematologic, and allergic and immunologic. So again, there's several review of systems. Whether or not they are pertinent and medically necessary is going to be whether or not we can count them. Your past family and social history. Your past history is the patient's past experience with illness, operation, injury, or treatment. So hospitalizations, medication, allergies, anything like that. Social history, age-appropriate review of past and current activities, marital status, employment, occupational history, military, education, sexual history, drugs and alcohol, tobacco. Your family history, review of medical events in the patient's family, health status, cause of death, parents, siblings, and children. It used to be that they would include non-immediate family, aunts, uncles, no longer. It is just parents, siblings, grandchildren. Some offices will include, like with my history of breast cancer, they did include my grandparents because my grandparents on both maternal and paternal had cancers. So that was included in addition. So diseases of family members that may be hereditary or place the patient at risk would be included. So your HPI, your review of systems, and your past family and social will be included in all patient encounters, and depending on the level of those, that's going to help determine the level of the visit. So when they do a history, so now we've reviewed the elements of the history, now we get to choose what level history does it qualify for. And again, it needs to be documented by the physician. So we have 4 different history levels: problem-focused, expanded, problem-focused, detailed, and comprehensive. So in order for this history to be problem-focused, it needs to be focused on the chief complaint and a brief history of the present problem of the patient. So review of the history, pertinent information about the chief complaint. So it centers around severity, duration, symptoms. Brief history does not have to include past family and social. So for a brief history of present illness, it will include one of 3 elements. And you'll see in a minute a page that goes into what those elements are. If it is an expanded problem focus, they focus on the chief complaint, brief history of the problem, and they do a problem pertinent review of systems. So again, here's where we have a ear infection and a sore throat. They're going to do review of systems that are only pertinent to that problem. So the ear, nose, and throat, maybe skin, but not other musculoskeletal or things like that. Detailed. Physician focuses on a chief complaint, extended history of the present problem. So this means they need 4 out of the 8, or 4 or more of the 8. An extended review of systems and the past, family, and social. And then for it to be the comprehensive, that's the most complex. They need to do the chief complaint, extended history of the problem, complete review of systems, and a complete past, family, and social. So your comprehensive is going to be the hardest to get. Maybe not if you're internal or family medicine, but if you're a specialist, some of those review of systems are really not going to be pertinent to what the patient is seeing you for. So some third-party payers have established standards for the number of elements that must be documented in order to qualify for that level visit. So, for example, a third-party payer may say for a comprehensive history, it needs to have an extended HPI that includes 4 of those 8 location, severity, that type of thing, complete review of systems, and at least 10 of the 14 organ systems, and then all 3 past, family, and social. So if you look on 294, when I said on the other page that a brief HPI has 1 of 3 elements, if you look under HPI on page 294, that's what it means. It would need 1 to 3. So it needs the location, severity, context, modifying factor. 1, 2, 3. So if you have 1, that's good. If you have 3, okay. For the review of systems, when we tie in the review of systems, it came up and it said, what did it say for review of systems? 10 of 14. So again, we don't need them all, but we have to have a certain number of them. And then past, family, and social. So look at the bottom. Here's the grid, and this is how I base figuring out my doctors. If it's a problem focused, under that HPI section, they're going to have 1 to 3 of those qualifying things documented. There does not have to be a review of systems, and there does not have to be a past, family, and social. If, in order for them to qualify as an expanded problem, the HPI is still 1 to 3, but we have to have 1 problem pertinent review of systems and no past, family, and social. For detailed, you need 4 or more of the HPI, 2 to 9 of the review of systems, and 1, so either past, family, or social. And then for it to be comprehensive, 4 or more of the review of systems, for the HPI, but look at that, you need all 10 for the review of systems, and 2 to 3. So what your physician is doing is when they are documenting, that is what they are looking at to come up with whether it's problem focused, expanded, detailed, or comprehensive. How much information they need to document to support the reason they're seeing that patient. Now, when you select a history level, the choice goes to the lowest level. So if the HPI level is 2, that could qualify as a problem-focused or an expanded problem-focused. The review of systems is a level 2, which is detailed, but the past, family, and social is a level 1. So in the detailed column, we have 2 of those items, correct? But we can't bill it as a detailed because we only did HPI as a level 2. So we have to drop that back to the one where we meet all 3. Okay? So in that instance, somebody might go to the provider and say, well, because you only did 2 HPI instead of 4, you are at a problem focused instead of a detailed. So had you have covered 2 more items in the HPI, had they have been pertinent, you would have been able to bill the next level up. Examination. This is the subjective information regarding the complaint of the problem that the patient is being seen for. So that now the physician does an exam to get this information. So this is the hands-on. We have the same 4 levels for the exam. Problem-focused, expanded problem-focused, detailed, and comprehensive. So for it to be problem-focused, it's limited to the affected body area or organ system. Expanded, limited exam made of the affected body area or organ system and other related body areas. Detailed, extended exam, affected body area, and other related organ systems. And then again, your comprehensive encompasses general multi-system exam and should include 8 or more of the 12 organ systems. And again, Medicare has specific guidelines for what they consider to be comprehensive, meaning it's very difficult to meet that highest level because it reimburses at a much higher cost than the other visits. If you look down below, we talk about body areas and organ systems. So here, your constitutional elements or your organ systems can be blood pressure, pulse, respiration, temp, height, weight, general appearance. And then your organ systems are also ophthalmologic, ear, nose, throat, and mouth, cardiovascular, and so forth. And then your body areas are head, neck, chest, abdomen, genitalia, back, and extremity. So how this plays in is if you look again at the levels of examination, the problem focus needs to be limited to the affected body area or organ system. So if it was a abdominal wound, as long as it's pertinent to the body area of the abdomen, we're covered. For it to be expanded, it needs to be limited to affected body area or organ system and other related organ systems. And the detailed, extended, not limited, of affected body area and other related organ systems. And then for it to be comprehensive, it's organ systems only, no body areas. And again, you will see it's 1, 2 to 7 limited, 2 to 7 extended, or 8 or more. So again, these are the guidelines that the physician, if it's a, real simple earache, chances are they're probably not going to be able to get a high-level office visit on this because of what they're going to be limited to examine. Patient's medical record needs to reflect the number of systems examined in a brief statement of findings. For example, if the patient came with a complaint of a small foreign object in the eye, physician would not typically need to do a cardiologic exam. The extent of the exam is based on what needs to be done to treat the patient. If you look on 298, here's a new patient, 8 years old, comes in with an earache, right ear. Mother says the child's been complaining of pain in right ear, severity of 8 to 10, past 2 days. They appear in mild distress. There's the vitals, so they've done a temperature. They've examined the ear, tympanic membrane read, fluid noted, health history reviewed, and there's a diagnosis. So from just that little documentation, we know the chief complaint, the HPI, we know the location, we know the quality, aching, we know severities 8 out of 10, and we know how long it's been happening, 2 days. Past family and social, they said health history reviewed. And in this case, the patient, the form was completed by the mother. So that would be in there. And then the review of systems, they did the ears. So knowing we've got 4 HPI, we've got the past family and social, and 1 organ system, let's flip back 2 pages to 294 and tell me what level history that description would qualify for. Would it be problem focused, expanded, detailed, or comprehensive?
Expanded.
Expanded, right, because we have a brief HPI, we have 1 to 3. We have the problem pertinent review of systems, the EARS, and we did the past family and social, but we can't include that as detailed because we do not have 2 to 9 review of systems. We only have 1. So we have to drop it back. Does that make sense? Mm-hmm. Okay. So with that same situation, now let's flip to the next page, 296, and what level exam would that be? Would it be a problem-focused, expanded problem-focused, detailed, or comprehensive?
Problem focused.
The
Yeah, it
physician
must just
focused.
head. Oh, sorry. Would ears be included in head?
Well, underneath where it says the ears, 1 organ system, it says in this case the physician focused on constitutional, which is temperature and general appearance, and 1 organ system. So that would actually qualify as 2.
Yeah, expanded.
Expanded, right, because if you look back at that table, constitutional also qualified for OS. And they did do the temperature and appearance. So that would also be an expanded problem focus. So we have the history, we have the exam. Now they're going to take into consideration the decision making on page 299. So the decision making is based on complexity of the decision that the physician makes about the patient's diagnosis and care. It's based on 3 elements: the number of diagnosis or management options, and they can be minimal, limited, multiple, or extensive, the amount and or complexity of data to review, and the data can be minimal, none, limited, moderate, or extensive, and then the risk of complication or death if the treatment goes untreated. And the risk can be minimal, low, moderate, or high. So if you look at medical decision making, we have, again, 4 levels. We have straightforward, low, moderate, and high. So for straightforward decision making, we're going to have minimal diagnosis and management options. Minimal or no data to review, and minimal risk to the patient if untreated. For it to be low decision making, we have limited number of diagnosis and treatment options, limited data to be reviewed, and low risk to the patient if untreated. Moderate complexity, multiple diagnosis and management options, moderate data to review, moderate risk to the patient if untreated. And high decision making, extensive diagnosis and management, extensive data to be reviewed, high risk if untreated. So again here, no data to be reviewed, straightforward. There's any data to be reviewed, it could be 2, 3, or 4. The thing here is for it to be high complexity decision making. Those are your patients that you will typically find have multiple diseases, illnesses, organ failures. Again, it's got to be a high risk to the patient if it's not treated. Management options. According to 95 documentation guidelines, they're giving us a rough idea of what the documentation should look like. So for each encounter, there's an assessment, an impression, and a diagnosis that needs to be documented for moderate decision making. So if they have a presenting problem with an established diagnosis, the record needs to reflect whether the problem's improved, controlled, resolving, or resolved. For a presenting problem without established diagnosis, the assessment may be stated in the form of possible, probable, question of, rule out. As you recall from our diagnoses, we can't code question of, but it can be documented that they are questioning a certain disease, illness, whatever it happens to be. Physician or providers, again, coders do not code rule out, possible, or probable. We code the symptoms. The initiation of or changes in treatment need to be documented, and that includes changes in medication. If referrals are made, consultations requested, that needs to be documented, so it should say who we are recommending that the patient see or where we are going to send them for physical therapy or another assessment. The data to be reviewed. If a diagnostic service, test, or procedure is ordered, planned, scheduled, or performed at the time of the office visit, that needs to be documented because that can count for data to be reviewed. Review of labs, x-rays, or other diagnostic tests need to be documented. So white blood count elevated, chest x-ray normal, negative, whatever it happens to be. Decision to obtain old records to get additional history from the family or anything like that. That needs to be documented because if we review those old records and we're obtaining them, we can get extra points to help us reach a higher level. Relevant findings from the review of those old records. Results of discussion of labs, x-rays, or other diagnostic tests with the physician who performed them needs to be documented. Direct visualization of an image needs to be documented. So on the next page, when we look at how to tally our medical decision making, if my doctor requests a x-ray report and he can actually look at the films as well, we can count both of those. So it gives us an extra bullet because he's not only reviewed the typed report, but he's actually been able to see the actual scans. If a surgical procedure is, went too far, the risk. So here are the guidelines for documentation for risk. Comorbidities, what are some secondary or underlying conditions that increase the complexity of that decision making? If a surgical or invasive procedure is ordered, planned, or scheduled, that needs to be documented. We get bullets for those. If a surgery or invasive procedure is done at the time of an office visit, that needs to be documented because that means it needed to be done sooner rather than later, so that might give us extra bullets. Referral for a decision to perform surgery or a diagnostic procedure on an urgent basis. The examples of the level of risk, again, found in table 11.1, so you can see down at the bottom. So if the level of risk is minimal, it means we have one self-limited or minor problem. And you can see they give us an example of ringworm, for example. If it's low, or level 2, we have 2 or more self-limited or minor problems, or one stable chronic disease, such as hypertension or cataracts. Moderate, level 3, 1 or more chronic illness with exacerbation, or 2 or more stable chronic diseases, or an undiagnosed new problem. And for 4, 1 or more chronic illness with exacerbation, acute or chronic illness or injury posing a threat to life, and an abrupt change in neurological status. So most of the time, the risk is probably maybe going to be minimal, low, but occasion you could probably get away with a 3 or 4 depending on the patient's situation. So look on page 302, and here's the medical decision making. So if the number of diagnosis or treatment options is minimal, the most we can ever get is straightforward. If we have limited diagnosis, it's low. Moderate would be multiple, high would be extensive. The amount of complexity of data, so minimal or none, straightforward. Limited would be low, moderate, and extensive, high. And then your risk, minimal, low, moderate, and high. So pretty straightforward for decision making. Now here, when selecting medical decision making, the choice is the majority. So you remember back on the other page where we didn't quite meet that one column, so we had to back step? Here, it's the column that has the majority. So if one column has 2 and the other column has 1, the column that has 2 wins. Okay? And again, you probably, like I said, we're not the ones selecting the codes, your providers are, but if we have to audit, then we need to understand how to come up with what the physicians came up with. You can see a couple options, An example on page 303. This is a established patient. They fell, scraped their arm. They did a problem-focused history and exam. She slipped on the ice. The abrasion is clean, no foreign bodies, minimal drainage. They washed it and drained it. So here, the diagnosis and management options, they're minimal. It's an abrasion, it's clear or clean. The physician data to be reviewed, it's minimal. The risk, if it goes untreated, is very low. So here, when the physician takes all this into consideration, it said we did a problem-focused history and exam, and you can see with the straightforward decision-making, problem-focused, it would be a 99212. Now remember, if they're established, we only need 2 of those 3 key components, but if you go to your CPT book and you look at code 99213, there's not a problem focus, history, or exam, or straightforward decision making there, so we would not be able to select 2 of those. So that's why it's the lower of the codes. If it was that's not even a good example because they don't even give you the choice. But sometimes it's going to be all 3 that you meet for an established patient. In this case, it happened to be all 3, but we only actually needed 2. So look on page 305 and look at number 5. So the patient record indicates a detailed history, and this is a new patient. Okay, so we have a new patient, detailed history, detailed exam, and if I had walked you through the top portion, you would have come up with low decision making. So we have a new patient, detailed exam, detailed history, low decision making. Look in your CPT book and tell me what CPT code that would qualify for. New patient, detailed history, detailed exam, low decision making.
99213.
Nope, you're an established. I
Oh,
said it was a new patient.
99201.
Why did you pick 99201? That's a problem-focused history and exam and straightforward decision making. We have detailed history, detailed exam, and low decision making.
oh, 99203.
99203, correct, because we have to meet all three of them. So a 99203, correct. And again, we're just starting on this, so we're going to do several more, don't worry. So again, there's a lot of information to be considered to choose the correct E&M code. So again, with practice, we will get much better at it. But again, a lot of times at the offices, we're not responsible for picking those codes. Your doctor is the one doing the service, and this is where your encounter or your super bills come in, because they are circling the levels that they do, and we are just transferring that information into our practice management system in order to create the claim. But we want you to understand how they get to that code. So, now we're going to talk about some contributing factors. So some things that can add to help that code increase possibly is counseling, coordination of care, or nature of the presenting problem. So for counseling, this is when the physician talks to patients and their families. It may be discussing test results, recommending x-rays, procedures, risk and benefit of treatment, instructions for treatment, compliance, patient and family education. Most of the time, counseling takes place at the time of every visit. Just pretty straightforward, but how in-depth they get depends on what's being ordered. When counseling is the reason for the encounter, or it consumes most of the visit time, which is typically more than 50%, then counseling would be considered a component of the code selection. So again, I just said that counseling is typically part of every visit. So the only way we can count counseling in addition is if it is more than 50% of the visit. So this would affect us in the gastroenterology office when we would see a patient with hepatitis C, because that patient would need to be counseled about all the different treatments for hepatitis C. And typically that would take up more than 50% of the office visit. So we could then count counseling. Coordination of care with other health care providers or agencies may be necessary for the care of the patient. So you might arrange, again, transfer for a patient to the burn center, long-term nursing care facility, anything like that, coordination of care. The nature of the presenting problem. This is the foundation of the level assigned. The presenting problem is the patient's chief complaint. And again, that chief complaint is what determines the level of care that the physician needs to provide to help diagnose and treat the patient. CPT describes the presenting problem as a disease, condition, illness, injury, symptom, sign, finding, complaint, or other reason for the encounter, with or without diagnosis being established at time of encounter. So a presenting problem can be minimal, self-limited, low severity, moderate severity, and high. So if it's a minimal presenting problem, it may not require the presence of a physician. So it could be a blood pressure reading, dressing change, stitch removal. Self-limited, also a minor presenting problem, but it runs a definite and prescribed course. It may come and go, not likely to be a permanent alter in health status. or the presenting problem has good prognosis with treatment. Low severity, risk of complete sickness without treatment is low, little or no risk of death without treatment, full recovery without impairment. Moderate severity, the risk of complete sickness without treatment, moderate risk of death, uncertain prognosis. High severity, risk of complete sickness without treatment, high to extreme, moderate to high risk of death, or strong probability of severe or functional impairment. And again, the medical record should contain physician's observation concerning the complexity of that presenting problem. And usually, depending on what they come in with, you can pretty much tell what level presenting problem it is. We have what we call direct face-to-face and unit floor time. These are two measures of time. Your outpatient visits are direct face-to-face time. This is the time the physician spends directly with the patient during an office visit, getting the history, exam, going over the results, and figuring out treatment. Inpatient time is measured in unit floor time. It's the time the physician spends in the hospital setting dealing with the patient care. Unit or floor time includes bedside care as well as nursing station care. So when they're in your office, the time that we can include, so to speak, is only the time that the physician is directly face-to-face with the patient. If they're in the hospital, we can include the time that they go in the room and they check on the patient and so forth. And we can also include the time that they're sitting out at the nurse's desk documenting in the chart or calling to get lab results, that type of thing. We can't include the time if they're sitting there socializing with the nurses, but anything that is pertinent to the patient care in the hospital setting. So direct face-to-face time, unit floor time. These statements concerning time are used when counseling and or coordination of care, again, represent 50% of the time spent with the patient, or more than 50% of the time, excuse me. So your physician discusses various treatment options, prognosis, risk of treatment. In this particular one, if the time was documented and the counseling is spent that way and the counseling is documented as taking more than 50% of the visit, this typically would come up to a 25-minute patient visit. The physician would document beginning and ending time, total time spent with the patient, total time spent counseling, and that can affect the code. Sometimes it's enough to bring it up just one level, but to give you an example, a mid-level new patient visit, for example, let's say it's $180, 99203. A 99204 might be $260. So it would be a difference of roughly $80 in that situation. So the hardest part is getting them to document the time in the patient record. Because doctors, typically, if they're not wearing a watch, we don't have clocks in our exam room because we know it just ticks the patients off. So the provider would either need to look at the computer to get the time or have a phone or something that they would be able to check the time. And that would need to be documented. I would guarantee you that if you can train your providers to document time, your increase in revenue, some offices would probably increase 25% because you would be able to bill higher level visits. Why does my son, he always forgets that I'm in class on the nights that I teach. He's from Wyoming. He never pays attention. So the big thing, time. Time was not included in your CPT manual before 1992, but it was incorporated after that to help the physicians and hopefully enable them to use time as factors in selecting the codes. If you look on page 308, these are just talking about the presenting problems. So this is just coming up with the diagnosis codes and then telling whether it's a minimal problem, self-limited, low, moderate, or high. Okay, on the bottom of 308, if you open to the first page of your CPT, which is, we've already been there, we have notes above the 99201 code. So you see, it's in the first column, it says office or other outpatient service, and there's some notes there, and then there's some coding tips. These notes highlight incidents in which the code in this category are appropriate for assignment. So again, physician's office, other outpatient, or other ambulatory facility. So again, by reading carefully, this does not just mean office setting. It can be an ambulatory setting. It can be a outpatient setting. But again, we need to read what's there, and that will, again, help us with these codes. So if you look on 309, we know the patient status. We know it's a new patient. We know what the code is, the 99201. We know the place of service. We said it was office or other outpatient. We know how many components we need to meet of that bolded. We need all three. And we know what the three key components are. And then we have the contributing factors underneath, reminding us that counseling and coordination of care are provided, and the nature of the presenting problem, the typical time face-to-face. Your doctors will use that, hopefully, in helping them select a code. The information will also direct you to other code subsections if the classification is not correct. So if you look above, so on that same page, page 11, right under the first column, office or other outpatient setting, if you look at the third paragraph, it says, for services provided in the emergency department, use 99281 to 99285. So this office or other outpatient is not the emergency room. It's telling us if it's in the ER, we need to go to a different set of codes. So again, that's when we kind of have to look through, and I found it very helpful before I sat for my exam to go through these beginning sections and highlight anything that stood out like that, like if ER, go to this, or if admitted and discharged on same day, use these codes. Anything that's going to help you. So again, we've got the key components, contributing factors, place of service, patient status, and then we have the codes. So now we're going to use that information that we took, and we're going to start using these codes. So as you see, first section in your evaluation and management is new patient. We talked about a new patient being somebody not receiving care within the last 3 years, and obviously a new patient reimburses at a higher rate than a established patient. So look on page 310 and look at number 4. We have a 53-year-old new patient, initial office visit for a vasectomy. History and exam detailed, medical decision making low. What CPT code?
99203.
99203. And when you take the exam, what I did, and it doesn't matter if you can bring a highlighter, you can use your pencil. When I read the questions, I would underline new, detailed history, detailed exam, and I'd underline what the decision making was. That way I didn't have to reread the whole thing when I finally got to the code to look for it. It was already done for me. So 99203. Now look at number 6. 23-year-old, new patient, initial office visit for depression, thoughts of suicide, more than an hour is spent discussing problems and options, medical history negative, social sleeplessness, strokes smokes between 2 and 2.5 packs of unfiltered cigarettes a day for 5 years, drinks 10 to 12 cups of coffee, denies the use of drugs. Actual patient record continues and indicates comprehensive history and exam was conducted and medical decision making was high. So we have a new patient, comprehensive history and exam, high decision making.
99205.
99205, right. And this is what you're going to be seeing. So we're not going to make you try to figure out what level they did when you're coding in your workbook and even on the exam. It's going to be this types of scenario. It will say detailed history, detailed exam, whatever it happens to be. So
Can
now
I ask you? Oh, sorry. So this, to me, I don't know about you, but this to me, this part is easier. But for me, I've been having a hard time figuring out what would I put first. So like if right below, there's going to be 4 ICD-10
Like, what would I code
codes.
first?
Oh, for your diagnosis codes?
Yeah. So there's
Wow.
going to be 4.
Right. So when it comes to your diagnosis codes, again, we're not the ones normally that are going to select what order those go in. They go in order of severity. So in this case, what you would do is as you're reading through, it tells you severe depression, report as first listed diagnosis code. Then as you go down through, it tells you the
Now that wouldn't
sleeplessness.
be on the exam, right? That wouldn't be put out on the exam like that. You would have to know that that's what you're going to diagnose first.
No, sometimes on the exam it's going to say that also, but the key on the exam is to, 1, put it in order of importance. So if you have a patient that comes in with, let's say, rectal bleeding and a fever, obviously the rectal bleeding is more severe, so we would put that first. The other key is when you look up these diagnosis codes that are already in your answers, to look for whether or not it says use additional code or code first underlying disease, or if it's italicized. Because if it's italicized, it can't be first.
Mm-hmm.
So those are the keys to look up when you're looking on, when you're on your exam. But
to me,
yes,
that's
in your
the
exercises, it's going to list it out for you.
But to me in this, it doesn't seem like there would really, like, what would you be diagnosing? Because you're not going to diagnose that they smoke, right? But you could say he has severe depression.
Well, no, the severe depression is your first one.
Yeah.
And then the sleeplessness is an additional. And then your report of tobacco abuse and caffeine are actually your 3rd and 4th code. Because there's like a history of tobacco dependence code. And that ends up being those additional codes.
Okay, is that why? So that's what's in the parentheses. So you could say that's tobacco abuse because he smokes. Okay.
Yep. But on the exam, when you take the exam, remember the answers are all going to be there for you. It's just pretty much when you go to look them up, 1, either putting them in importance of urgency, so to speak, or severity, or whether or not it says code first and you know something's got to be in front of it, or it's italicized and then you know that it can't be first. Yeah,
So then
and
the
you'll see
fourth
what
one would be like would be the one that says encounter for new patient. Would that be your fourth?
No, the tobacco abuse and dependence. There's going to be 2 codes with regards to the tobacco abuse. There will
and
be
alcohol.
one. Yeah, there's one that says. I'm trying to remember what it is. Actually, I can tell you. Hold on one second. 11.
So you wouldn't code that there wasn't like a office visit?
Well, your office visit is your CPT code. That's what we
Okay.
came up with the 99205. But then
Okay.
your diagnosis codes are the 4 that we were coming up with. So for number 6, your diagnosis codes, you have your depression, and then they have, so depression would be first, so maybe put a little number 1 over that for when you look that up.
Yeah.
Your second one is actual frequent thoughts of suicide. So you'd have ideations for suicide would be your second diagnosis code, which is your second line, frequent thoughts of suicide. Your third one, they actually put as the sleeplessness or insomnia. And then the fourth one is the dependence of nicotine. So they actually put the suicide in there as well.
That's where I don't like. That's where I get confused sometimes when I'm reading these, because if you're, just regular reading it, the frequent thoughts of suicide. So your thoughts, it seems weird that it would be something you would diagnose it, a thought.
Right. But again, we're not the ones that are picking the diagnosis codes, the providers are. So in this office visit, what you would see is when the super bill comes to you, your doctor would actually, we don't use our super bills anymore because we're all electronic, but our old paper super bills, it would give you the patient name, and then it gave you all of the CPT codes that we used in the office. So your doctor circled what level, and then we had like several columns of frequent diagnosis codes that we used in our office. But down at the bottom, we also had several lines where we put other diagnoses. So what our physicians would do is they would circle the diagnoses as long as they were there. And then if there was one that they needed to add, such as the suicide, they'd write it under other. And
Okay,
then
so
when
we don't
go
have to
key that
decide.
in.
They're
No,
gonna
we do not decide.
because I'm looking
The
at this and I'm like,
provider does.
how would we know what they want us to diagnose in just like a paragraph? So they they kind of pinpoint, this is it, this.
Yes.
Okay, all right.
Yep, absolutely.
So now I feel a little better about that.
Yeah, you'll never be by yourself on that. So after your new patient, we have established patient. So again, your established patient is somebody being seen within the past 3 years. Your first code that's in the established patient, the 99211, typically does not require the presence of a physician. So this is typically a quick blood pressure check, maybe a stitch removal, maybe an injection, immunization, something like that. On page 312, let's take a look at number 5. So what I like about this book is it's nice that it tells you what section, we did new, now we're doing established codes only. In your workbook, it will do the same thing, but there will be one section that it won't tell you what section of code it is, but overall it does. So number 5 is a 61-year-old established patient, medication management, hypertensive, expanded problem focus, history and exam, moderate decision making. So look at your established patient codes, and we have expanded problem focus, history and exam, and moderate decision making.
9923.
99213, right, because we need two of the three key components.
Yeah.
So you have your history and your exam. Your decision making is more, but if you look at the next code up,
The
we
other two are
can't
more.
meet a detailed history and a detailed exam. Correct. Good, 99213. And then number 6, established patient, infected skin tag, problem focused history and exam, low decision making.
99212.
99212 for the same reason. We can do the history and the exam, but we can't do the low complexity is the next code up, but we can't meet that level history and exam. So as we are going through this, do not get frustrated. It does take practice. The more you do it, the easier it gets. We'll go ahead and do the hospital observation, and then we'll leave off there because I don't want to get right in the middle. So your next section is hospital observation, 99217 to 99226. This is initial hospital observation, subsequent observation, and observation discharge. These are for patients who are in the hospital on observation only. So observation is a patient who does not have an illness severe enough to meet inpatient criteria. So in other words, they are not formally admitted. They are observed. These codes are for new or established. They again range 99218 to 99222. So if you look at those particular observation codes, 99218 to 99220, these are our initial observation codes. So this would be, if they were in an inpatient setting, it would be like their admission. So this will be the initial visit. Then you'll see with these, it needs all three key components. So it doesn't matter whether you've seen them before. They may be a frequent flyer to your office. They could have been your patient for 12 years. Doesn't matter. Observation, you have to meet all three key components. If you look under, right above the quick check, if a patient is admitted to the hospital as an inpatient after having been admitted as observation, you cannot report observation status separately. At that time, it switches to hospital admission status, so you would bill the admit code instead of observation. We have one code for observation discharge, pretty simple, 99217. You can read it. It's pretty straightforward. It just tells you it is discharge, other about observation, blah, blah, blah. But if you also look right above that observation discharge code, it tells you if the observation or inpatient hospital care includes admission and discharge on the same date. To go see codes 99234 to 99236. So again, little extra tidbits, and even under the initial observation care, it tells you about if they've been admitted after being observation, what codes to go to, when observation status is initiated, at another site of service, and so forth. So a lot of extra information there. Your initial observation care, again, that's the initial visit. These codes include development of a care plan for patient and reassessment while on observation status. Observation admission can only be reported on the first day of service. Again, if they're admitted and discharged on the same day, then we go to codes 99234 to 99236. If the patient's in the hospital overnight but remains for a period of less than 48 hours, the first day would be reported with a code from 99218 to 99220, the initial observation. And the second day would be coded with the 99217 for the discharge.
So a day is considered 24 hours?
Yeah, typically. Yep. If your patient is on observation status longer than 48 hours, it tells you your first day would be 99218 to 99220, and your second day 99224 to 226, and your third day 99217. So remember, we have subsequent observation. Typically with observation, you are going to find that a lot of times if they're in observation, hopefully they're not going to be in observation longer than 48 hours. If they need to be in observation longer than 48 hours, most physicians are actually going to admit them. And the reason they admit them is because a lot of the insurance carriers have guidelines as to what you just said, how long they consider observation. So some insurance companies consider observation 24 hours and then they're considered an inpatient. Others consider observation 48 hours and then they're an inpatient. So that's going to vary. And then again, the last of the observation codes is subsequent observation care. So these are 99224 to 99226. So this would be day 2 until the date of discharge. And you will see that for the subsequent observation, we only need to meet 2 of the 3 key components. When reporting these services, Medicare requires a patient to be admitted and observed for more than 8 hours. So if it is less than 8 hours, Medicare does not consider that observation status, and it would be billed with either a ER visit, if that's where they're being observed, or a code for an outpatient facility code. But Medicare requires at least 8 hours for observation codes to be billed. Okay? So what we will do is next week, we're going to go, again, start more. We'll go into the hospital inpatient, go through the ER and all that. So what I would tell you to do is just worry about the other 2 chapters that we did for now. If you want to try your workbook without, going further in the E&M for lecture, go ahead and try. But otherwise, hold off until we cover the rest of the E&M chapter. We'll finish that hopefully next week, and then we'll go into chapter 13 for the surgery, general surgery guidelines. And again, we're just going to cover each section of that CPT book from now till the end. And sometimes we are going to use both CPT codes and ICD-10 codes, and other times you're going to see it's just going to ask for the CPT codes. But we will have some of both so that you continue to use your ICD-10 book as well. Any questions? No?
No.
I'm also in the process of waiting to hear back from the school with regards to school vacation. They are not sure whether the week before Christmas, whether we would have class on that Thursday night. Originally, I think school closed like on that Wednesday, which if that is the case, we would have that week and the following week off. But because of the storm a couple of weeks ago and this particular school being closed for a week, there's now talk that they may have to go that entire week and only have the week of Christmas off. So as soon as I know whether or not it will be 1 or 2 weeks for classes, I will let you guys know so then you can plan your catch-up accordingly if you need to.
Okay.
I can't come on the 21st. Do I email you that? Well, I could, but it's my son's 5th birthday, so I don't want to.
Oh, yeah, no, that's fine. If you're telling me now, that's fine. If we end up having class on the 21st, then what I do is I would have you watch that lecture. But
Yeah,
if we
I'll watch
don't
it
have
over the
class,
weekend.
yeah, if we don't have class on the 21st, then you won't miss anything.
Okay.
But you'll know before then whether or not we're going to have class.
Okay.
Okay? All right, so we will see everybody next week.
Have
Thank
a good
you.
week.
All right, you too. Hi, babe. My class goes from 5:30 to 8:30, honey. No, it goes till 8:30. What do you need, sweetie? Oh, hi. How are you? I know. Everybody forgets I'm in class.